Hello, Steven. Just gonna give like a minute. Okay, I suppose we'll get started unless anybody needs more time. Um, this is not the 50 people that I wanted to attend, but that's okay. Less paperwork for me at the end of the day. So it's just a quick training, just a little refresher about anaphylaxis. I had a case recently, and Scott O'Brien had one, I think last February, that were pretty refractory. So the theme is going to be, first of all, can everybody hear me okay? Sorry.
Yep.
Sweet. Um, I know, Scott, thank you. Um, so, and then you guys had another ambulance there too, didn't you, Scott? Not just yours? Oh, okay. Without further ado. Hmm. Share my screen. Sweet. Okay. I could not figure out how to separate my speaker notes and do this at the same time. I'm so sorry about that. I don't have two screens, which apparently makes it easier. But anyways, okay. Critical emergencies, anaphylaxis, refractory shock, and airway compromise. Um, if anybody can monitor the group and let people in if anybody comes in, and then if anybody has a question, just stop and ask. There's only like 10 or 11 of us, so this should go pretty quick, and it could be more of an open-ended discussion if you guys want. So just chime in whenever. Uh, we're going to just talk really quickly about what is anaphylaxis, what the refractory shock portion is, airway compromise, and how it applies to emergency management. All right. So this is just the general NCCP 2025 NREMT type of thing. Well, let me share. I got a presenter view, sorry. Yeah. Um, this is the stuff that kind of hits the NREMT style research because we're in the research cycle. So anaphylaxis is an acute systemic allergic reaction primarily caused by IgE mediated immune response. They trigger mast cells and basophils to release chemical mediators during anaphylaxis. The release mediators cause vasodilation, increased vessel permeability, and bronchoconstriction. Common causes, allergies, um, foods, insects, medications. Previous anaphylaxis is a risk factor. I'm not going to get into anaphylactoid reaction, which I think is IgM mediated, but can present with some similar symptoms just without the hypotension. But a history of asthma, cardiovascular disease, and the longer you wait untreated, the greater the risk of severe complications are. Um, skin manifestations. Common kinds of symptoms are urticaria, angioedema. Um, we're going to talk more about angioedema in a second. Respiratory distress symptoms, wheezing and stridor, cardiovascular symptoms like hypotension or tachycardia, and then GI symptoms, nausea, vomiting, diarrhea, urination, and abdominal pain. Okay, refractory shock and anaphylaxis. You give a patient medication, presumably, if you're following a state protocol, it's some combination of albuterol or Duanab, epinephrine, IM epinephrine, um, maybe steroids, and then if they have urticaria, maybe Benadryl. But with refractory shock, for the most part, you have profound vasodilation, which leads to excessive or refractory hypotension, substantial capillary leakage, myocardial depression. That's what's actually causing the reduced cardiac output and low blood pressure, and other signs of shock, like acidosis or organ failure, and altered mental status. Persistent hypotension, signs of poor perfusion, altered mental status, tachycardia. And then if you happen to take a patient up to UVM that uh, is in profound refractory shock, then perhaps you see some labs evidence of that, like acidosis um, or low PaO2 or something like that, abnormal blood gases. Management is epinephrine administration, sometimes repeated doses and even infusions. Fluid resuscitation, that by itself is probably not going to help the hypotension, but it is an additive or conjunctive therapy. Vasopressors and then supportive intensive care. The most critical is probably airway management. Even with an endotracheal tube, uh, patients could still die from bronchoconstriction, which can cause incredibly high PIPs even with a endotracheal tube in. So just securing the airway with an endotracheal tube does not guarantee survival. Controlling the bronchoconstriction is what's really necessary for survival. In fact, most of the people that die from anaphylaxis die from severe bronchoconstriction. They don't die from hypotension or any of the other symptoms. They die because uh, they have a huge ventilatory shunt and they're not oxygenating to large portions of their lungs. Okay, airway compromise, upper airway edema. I think you can have swelling from the lips to the tongue to the supraglottic structures in the epiglottis all the way down to tracheal narrowing around the pharynx and the larynx. Bronchospasm and mucus plugging, which creates VQ mismatches. And then laryngeal spasms, which cause transiently elevated peak airway pressures and hypoxia. Key symptoms to observe is observed for stridor, hoarseness, difficulty breathing, use of accessory muscles, as well as altered mental status or anxiety, early indication on your physical exam, and really just pulse oximetry and end tidal are crucial for long-term airway management. Emergency airway management techniques, this is all pretty standard. It's just a review. If I'm going too fast, just let me know. Airway positioning, supplemental oxygen use, nebulized epinephrine. I didn't write albuterol on here, but that's important too. And then endotracheal intubation or maybe a surgical airway might be needed. I think we're almost to the end of these slides. So our protocols stress early anaphylaxis identification and administration of IM-epi, sometimes repeated dosages followed by an infusion. I don't know if we can go up to 10 or 20. I didn't really review the protocols too quickly, but some patients could require high dose epinephrine for hours, if not days. We're going to get into some complications of this in a second here. And then airway assessment. Epinephrine's primary, followed by antihistamines, corticosteroids, albuterol. I think a lot of people focus on IM epinephrine and they forget the albuterol, but really the bronchospasm is what kills people the most. Oxygen as needed and IV fluids, and then supportive care like positioning and patient comfort. This is just a generic NREMT-ism. get prescribed auto-injectors, follow up with an allergist. Okay, conclusion of this PowerPoint slash NCCP recertification bullets. We reviewed anaphylaxis, refractory shock, airway compromise, urgent medical attention, and up to surgical airway and continuous epinephrine in albuterol therapies. Early identification can save lives, and then patient education. I don't know, maybe as we get into community medicine, we might start talking about stuff like this. Okay. I wanted to hit on a couple of things at the beginning of this, but I just wanted to get through the meat and potatoes of the slide. Um, and this will be kind of an open discussion, so feel free to chime in. Okay, I'm going to stop sharing my screen just for a second. Who has been to? I know Scott and Rachel obviously but who else has been to severe anaphylaxis? Anybody? Oh, Blair's. Oh, did you not see my slide, Eden? Hmm.
It did end up coming up.
Okay, sorry. Yeah, go ahead, Blair's.
Oh, you just asked about who's
Oh, yeah.
seen severe
Okay.
anaphylaxis.
Yep, great. So, I don't want to bounce around too much, but I'm going to get into my case a little bit just to highlight a couple of points. I got to a guy a couple of weeks ago. I think I was working with Willis, and he didn't have any hypotension, but he had stridor. He was hypoxic and he had wheezing, and he was really, really anxious. Cabot had given him um, an IM epi. East Montpelier gave him IM epi, and then his girlfriend gave him an auto injector. The point of this is I have no idea out of any of that epinephrine if any of it worked. So certainly a dose administered by any of you when you get there would probably be warranted. That being said, assuming they did work, you're now at dose 3 or 4. You're at multiple doses, so you should start considering high. You should start thinking like an infusion. The other thing is I feel like everybody that does any sort of anaphylaxis just kind of vicariously gives Benadryl. According to the protocol, Benadryl is administered for urticaria, so that's itching and hives. It certainly has, I mean, excessive histamine release does cause more symptoms than just urticaria. So I think there is a place for it. I just wouldn't prioritize anaphylaxis versus allergic reaction. Yeah, I kind of alluded to that, but we will, Scott. Thanks. I wouldn't prioritize Benadryl over epinephrine or albuterol. So anaphylaxis, Scott just asked if we could go over that between that and allergic reaction. An allergic reaction is just an immune-driven response to any allergen, whether they have exposure previously or not, that causes some sort of allergic reaction symptom. That could be sneezing, urticaria, histamine release, any organ system really. When you get into anaphylaxis, it's 2 or more body systems or hypotension or airway compromise by themselves constitutes anaphylaxis. So if you have an exposure to an allergen and you have just nausea and vomiting by itself, that's not considered anaphylaxis. If you have hypotension requiring vasopressors or fluid, or you have airway compromise, then you have anaphylaxis. Additionally, if you have 2 or more body systems involved, even without airway compromise or without hypotension, for example, if you have nausea, vomiting, abdominal pain, and urticaria or hives, then you have more than one organ system involved. That is also anaphylaxis, and you should still give epinephrine. My experience has been in the absence of hypotension or airway compromise, typically people don't require multiple IM administrations of epinephrine, but I suppose they always could. Can I answer your question, Scott? Ooh, that's a good question, Ben. What's the benefit of nebulized epi over IM? Okay, so this is also something that I wanted to get into a little bit later, but we'll go over it now. Racemic epi. Let me share my. Oh, you guys can see my screen still. Great. There's this trial. So this trial differs from caveat, fair warning, what I'm about to show you is not part of the protocol. So I don't think you can do what's on here. Um, and then not get a protocol like, hey, why did you do that? But there's this Amex 4 algorithm, which talks about, I'll just show you what it is. There it is. Um, high dose epinephrine. So this is if somebody is unconscious, they need assistance ventilating, or you've given repeated doses of epinephrine and they're still hypotensive or still have bronchospasm, airway edema, stridor, or like significant oral edema, I suppose, then there's this physician-run Amex trial, which talks about hydrodose adrenaline, muscle relaxant. So that would be um, like terbutaline, ketamine, magnesium, things like that. Um, the best intubator on scene to do the intubation with one pass in success. FONA just stands for that's a surgical airway or a surgical airway if needed. And then the X, extreme ventilation, extreme bronchodilators, extreme extra vasopressors, and then consider pneumothorax if you continue to have high PIPs, which I don't know, that's a little bit above my pay grade. I think the person would probably need to have a chest x-ray at that point. And the 4 comes from 4 minutes of hypoxic brain injury. So on this study, then they also talked about racemic epinephrine for patients that have persistent stridor. I don't think that anything other than IM epinephrine is going to start to fix bronchoconstriction or hypotension. So IM is definitely the systemic choice, followed by an infusion if you're giving multiple. And then the nebulized epi is really only proven to work at like the supraglottic and glottic structures. So if somebody has airway edema from the like vocal cords up, then there's benefit of nebulized epi. We don't carry true nebulized epi. We would have to like make some sort of I don't know, impromptu version, which I don't actually remember how to make. If anybody can remembers, you can either say so or put the instructions in the chat because I don't remember how to do it. You mix like maybe half or a milligram of epinephrine with like 2.5 or 3 milliliters of normal saline. And apparently it's supposed to be sort of equivalent to racemic epi,
Mickey,
although
it's
what?
it's 3 milligrams and 3 mLs of the large
Okay,
vial.
well,
So you take
that's a
three
ton.
mLs of that. Yeah.
Yeah, okay, that's a lot. I don't even know, is that in our protocol? I'm not sure. I would probably do it if all else fails.
It's in the croup and bronchiolitis protocol for peds.
Oh, okay. Well, yeah, there you go. Just pretend your patient's small. Hmm. All right, thanks, Steven. Did that answer your question? See that
Yes, it
that's
did.
what I thought,
Thanks.
Kaylee, but yeah, I thought it was 1 milligram. But Dr. Stein also put something out like a year or two ago, and I don't have the email anymore, and she said some mixing instructions, and I think it's what Steven said. So I don't know. Some clarification might be needed.
At school, they just taught us that it was supposed to be like 1 milligram, 1,000, and 3 mLs of saline, but I don't know how on top of it they are.
I'm not sure. To be honest with you, I've only had an anaphylaxis patient twice in my life, like in 15 years. And the amount of times that I consider racemic epi during both of those encounters were 0. So I wouldn't suggest not being aware of racemic epi. Um, but honestly, maybe we should just purchase it. Like it comes in, it's the exact same size as a normal nebulizer thing. I suppose there might be the chance that they could be confused and people like if we have albuterol, a duoneb, and nebulized epi all in the same bag, maybe people might get confused. Yeah, I see what you just put in, Stephen. Is it under paramedic or is it under A? Oh yeah, consider
It's under
epinephrine.
paramedic down in croup.
Yeah, you're right.
specifically.
3 milligrams added to 3 mLs. Well, to be honest with you, if that's the pediatric um Is that pediatric or is that adult on top? I can't see because the screen's in the way.
Pediatric.
Yeah, I mean, if that's safe for pediatric administration, I don't see why it wouldn't be safe for adult administration. All right, GBD. So, yeah. Other part of this, has anybody ever seen a patient that had only angioedema? Um, this happens sometimes with uh, what is it, like ACE inhibitor, like lisinopril. People that have allergies to ACE inhibitors that are recently put on them. Yeah, for an ACE inhibitor. Um, so I guess that's an important distinction because outer airway edema just of the tongue and the lips is very, very unlikely to have um, any hemodynamic involvement aside from maybe just a little bit of discomfort and drooling, and maybe it's just tough for them to talk. Yeah. So because their tongue is enlarged on the front part of it, it might be hard for them to swallow, but there's no actual airway compromise. So I think the treatment for that is to just stop taking the medication and then just do supportive therapy. I've seen some physicians give TXA before for it, like 2 grams of TXA. But I don't think that anything we have, yeah, maybe steroids. I don't think anything that we would give under anaphylaxis or allergic reaction protocol would benefit that at all. So I would just monitor them. I mean, put them on N-Tidal or something like that and just watch them. Yeah, definitely not in the protocol. In fact, I've seen physicians withhold PXA and just do watch. I mean, they'll watch these people for like 6, 8 hours sometimes. Um, but that's an important distinction because I've also seen patients. The last anaphylactic patient that I had did have only upper lip swelling and tongue swelling. So he actually couldn't stick out his tongue all the way and say ah, so I could look at his airway. So I actually had no idea what his pharyngeal, like supraglottic type structures look like because he couldn't stick his tongue out of the way all the way out because the upper lip and the first part of the tongue were swollen. And in an anaphylaxis setting, I'm not sure if racemic epi would help that. I don't think that it would be absorbed, but anyways, so that's one thing I wanted to talk about, the difference between the angioedema by itself in, an ACE inhibitor setting and, compared to what we're talking about, which is anaphylaxis. That's really it. That's like the gist of kind of what was on the agenda to talk about. And then Scott and I have some cases. I'm going to talk about mine really quickly because I already talked about like half of it, and then Scott can take it away for the rest of his because his was more significant than mine is. You guys can all see this, right?
Yeah.
Okay, cool. Um, so I had a 42-year-old male, the allergy. He's had allergic reactions before. He knew he got stung. The stinger was still in, but it was weird. His hand was wrapped because he had like carpal tunnel surgery. So his hand was in like a pretty tightly wrapped like ace wrap, but it wasn't quite a hard cast, but it wouldn't I would have had to cut it with trauma shears. Um and so I didn't have any ability to like really see the stinger. And then I think you can maybe make an attempt to remove it, but I just left it. And he had gotten epi from Cabot, from East Montpelier. The girlfriend gave him an EpiPen. I actually ended up on giving him 0.5 milligram IM epi, and he had stridor and he had wheezing. And then right out, as soon as I gave him the 0.5 of IM epi, he his wheezing got better. The stridor was still there, so I put him on an infusion. Then his wheezing came back. So I think I had him on like 8 or 10 micrograms a minute of epi. And his wheezing came back. So then I just gave him a bunch of epidural. I think I poured like maybe 5 things in the canister and then just left it on him the entire time. Here's a question for everybody. I wasn't sure how well the albuterol was reaching kind of like the lower bronchial tree area. I wasn't sure of its effectiveness. I chose to bring the CPAP or the Zoll, the BiPAP unit with us. I feel like positive pressure would probably help overcome airway resistance if there was airway resistance, because some of these patients can have, like when they're intubated, you can have PIPs of like 50 to 100. the same time, the MX trial that I just showed you guys recommends not doing mask or LMA ventilation. So I don't know if it means mask by BVM or if it means any mask. And I'm not sure, based off my research, if dry air through an or non-invasive positive pressure mask would potentially worsen the positive, or increase the likelihood of having laryngeal spasm or epiglottic structure irritation, which may further exist. So that's what I wasn't sure of. So I didn't do it. But that's just kind of a question I'm posing to you guys. I mean, if you weren't sure if the albuterol was reaching where it needed to go, would you consider BiPAP? I mean, I don't know. This is a gray area of medicine, in my opinion, and I have not arrived to a conclusion. What's the general consensus? I don't think there's any wrong answers.
Mickey, a big reason why they don't recommend you using a supraglottic or even BVM ventilation. Like if you have to BVM, you have to BVM. But the thing is, like those mask ventilations aren't going to help get that medicine in as much as you think it is. The person really needs an endotracheal tube or a crike because then you can add actual pressure. Because once you get above 15 PEEP, the pressure of the bag valve mask and the supraglottic airway leaks, and you don't really get anything. So I think that's why they recommend against it. I think you just need to be super aggressive on your medication routes, like just throw everything you got at them.
Yeah, no, I agree with you, Scott. And it's just hard in our particular setting because if a patient's not at the level where you would crike them, then you're obviously not going to do it. And if they're still awake and spontaneously breathing, then you need to RSI them, which we're not doing. So I think I would
Still
probably
nasal.
rather, what's that? Yeah. I
You
think
could
I'd
try
rather
rodeo.
put them on. I think I would rather try. I mean, like this is in conjunction with continuous epi, continuous NAB, steroids, the whole 9 yards. I feel like if I'm like, oh, if I'm in this waiting period where they're not quite bad enough to intubate them, or they're still conscious, or they're not dead and you can't, there's no real way to crike them without like causing them a lot of pain and then probably getting in trouble. I feel like I would try BiPAP as like this is my last possible resort. But I don't know. I was a little bit nervous about it, so that's all. So
I just think
you're
you
gonna say
just
something,
got to be
Scott?
more aggressive with the meds, as you'll
Yeah,
see.
and I think people the Annex trial that I showed you guys again, it talks about the fact that people underdo albuterol. Some patients need like 100 milligrams of albuterol over like 2 hours, hundreds of milligrams of albuterol. Like every single neb you have in the ambulance, minus the duo nebs, because we can't give more than 1.5 milligrams of tropium. Every single drop of albuterol you have in the ambulance, you may need. So that was one point that I wanted to stress. The other point is I really don't think that there's any issue if you had to putting somebody on an epi infusion and then also possibly giving intermittent IM doses in addition to the infusion that's going in. I didn't get to that point. I had him on just an infusion with continuous nebs. I did end up on giving him magnesium because he just kept wheezing, which was cool. They ended up on doing a CBC on the guy, and then his mag level was like 4.5. So I'm pretty sure I did that, but that's okay. And then, funny enough, he sat in the ED for like 6 hours on an epi infusion the entire time, and he was going to get admitted to the Dr. Blum was actually moonlighting and was going to admit him to the ICU overnight, and then he left AMA. So I don't know. I mean, he required a ton of epinephrine, and then he left. So I don't know. Good luck to him. So that was my case. Scott, do you need to share your screen at all?
I do.
Okay, I'm gonna stop sharing. Does anybody have any questions or contributions or comments so far before Scott starts in with his? Okay. Good luck. Thanks,
Oh
Jason.
God, I'm so nervous. Can you guys see my screen?
Yep.
Cool. So this is the stuff to be go over. I'll try to be quick so I don't waste anyone's time. But this is the dispatch information. A male with an allergic reaction, unknown cause, Benadryl on board, no epinephrine available. We went to the scene and we found the patient. We found a family member waving us in, and we found the patient at the base of a staircase on their left side, and they were verbally responsive. Chief complaint, altered mental status. What do you guys think of this initial dispatch?
It's a little bit ambiguous.
Yeah.
Well, actually, no, I take that back.
Okay. Have a good one, Jason. Be safe.
It seems ominous, actually. It seems legit.
Yeah. It seems like they're worried about this person. So yeah. Um, the verbal responsive and at the base of the stairs, does that make people feel worse? Better?
Worse.
Worse. Cool. Yeah, that's what, like, when we saw him initially and he was verbally responsive, that's kind of like an oh shit button. So here is. Yeah. Patient was initially only verbal, responsive to verbal and unable to answer your question. Family members provided a history. 2 hours prior to arrival, he started having these feelings. He self-treated with Benadryl, which he normally takes for when he has these reactions. He's taken 2 oral Benadryl prior to EMS arrival. He's eaten pizza, Domino's type, if you must know, before developing symptoms. Began feeling unwell, a rash progressed, upset stomach, lightheaded. Before EMS calls, he was able to lower himself to the ground at the base of the stairs, had no significant medical history, illicit drug history, had a few beers, and he weighed approximately 110 pounds. So what does this tell you about the route of allergen this person got? Like, was this person bitten by a bee? Did this person eat something? Did this person rub up against something? Ingestion. Cool. So if you think about ingestion, it's kind of the worst route to get an allergen because the allergen is still inside of you, releasing that histamine response. Unlike a sting or contact where your body gets that allergen and then overreacts, the allergen stays in your system and it releases histamine to get that allergen out, but the allergen is still in there. So the histamine response is just getting worse and worse as your intravascular volume depletes because it third spaces. You release more histamine, it becomes more histamine concentrated, causing the reaction to get worse and worse. So it's kind of like a histamine response that goes out of control at this point. And then I will lead. I'm not going to put down my whole narrative, so I'm just going to give you the key points because I don't want to waste anyone's time. Here's the initial airway. Here's the initial assessment. The patient was responsive to painful stimuli and loud verbal stimuli with 1 to 2 words before going silent again. Decreased mental status. The patient was 28 NPA was placed without difficulty. The patient had visible facial swelling and did not comply with EMS's commands to open his mouth. His skin was covered in diffuse hives. Blood pressure was initially unattainable. Oxygen saturation was at 80 to 95 at room air. So is this person someone that you think you should give epi to?
Yes.
Yeah.
Yes.
So I want to knock off one of my things. Do you think for someone that's 110 kilograms, do you think a dose of epinephrine 0.3 milligrams is enough to stop this reaction? Knowing that this is an ingestion route and knowing that this patient is rather large, do you think 0.3 is going to necessarily touch that? I understand protocol and I understand I need to use protocols better, but do you think 0.3 is going to be enough for this patient? Just estimate it.
Maybe not.
Maybe not. So I used to be really against the 0.5 dosing of epinephrine, depending on the system you work for and whatnot, and being more aggressive with epinephrine. With these larger patients, you're going to see that you're going to have to give more epinephrine before it even starts touching and starts reversing that reaction. So just if you have a patient that's over 100 kilograms, be Johnny on the spot with that epinephrine because 0.3 may not even be a therapeutic dose. Some things to note when you give 0.5 is that you may lose the ability to get a good accurate SpO2, and you may have that vasoconstriction, that nausea, vomiting. So just understand if protocols get to the point where we can do that and you start doing that, just know that, hey, you may have to be faster with that. So we gave him initial epinephrine. It took 3 doses of epinephrine. No, took 5 doses of epinephrine to get a readable blood pressure of 66/46. So the next thing, and this is something that I learned that day, what is the max dose of epinephrine that we're supposed to give as EMS providers?
I don't honestly know the answer to that question.
Oh, okay. Well,
I
this
would
is
say
an
maybe, I'm gonna guess, but maybe 3.
Yeah. So after 3, that's when you need to jump to that bridge to infusion. I can tell you right now, I was nervous at this time. We were giving him oxygen via non-rebreather mask, and I was kind of just getting him to a point where I could put him to infusion. We're trying to get IV access. I chose not to do IV access, uh, not to do IO access because his whole family was there. We tried to move him onto the stretcher, and as soon as we moved him, he fainted. By the way, other people that were on this call were Eastman and Rudy. You guys are here. If I miss anything, please let me know. I would really enjoy your input. So we didn't do IO access, which in hindsight, after 3, and if they're this symptomatic because they have the ingestion, just go right for the IO and go to an infusion. I actually set up the epinephrine infusion. I set up push dose epinephrine, but I never got to it because I never decided to give him actually go down the access thing. Uh, Other things that we did is we used different IM injection spots to not make, like if we all use the right lateral thigh, after the first few epinephrines, they're not going to be as effective because you have that vasoconstriction. So understand if you're doing IM injections, after 2, maybe switch the site up is another good one to think about. Went over that. So I will read you some vital signs. So what happened is we arrived, we put an NPA in, we gave him oxygen, and then every 2 minutes until we got to 10 doses of epinephrine, we were giving IM epinephrine 0.3 for blood pressure, mental status, and more for blood pressure and stuff. Yet again, when I say that out loud, after 3, just go right to the infusion. That is the correct thing. And the only epinephrine I regret on this patient, only epinephrine I regret is the 10th dose of epi that I kind of gave because I didn't want him to desaturate on the way to the ER. Note, when you give high dose epinephrine like this, nausea and vomiting will occur. This patient went from somnolent on the ground, near peri-arrest, to alert and oriented, talking and being thankful with an NPA in his nose, thanking us for doing a good job. So like we saw this patient turn around 100% from someone that's near dead to someone that's totally fine that vomited all over the ER's floor, which probably, because this is an ingestion route, probably helped him out more than he thought. That getting that antigen out of him was probably the best thing he could do for himself. Didn't think about steroids in this patient because they're not in protocol other than extended care. So just fun facts. We did 6 IV attempts. First blood pressure, which was 15 minutes after our arrival, after 5 doses of epinephrine, was 65/46. After the 8th dose, it was 86/58. And then the last blood pressure, last set of vitals at the hospital was blood pressure 122/89, heart rate 144. Kind of expect that with how much epinephrine we gave. Respiration 16. That was with end tidal, so I swear to God it's true. Oxygen saturation 94 on 15, and end tidal is 34. So this was kind of a really good like call to see. I think it was a weird one because like we don't really get taught about like the different levels of ingestion, like different levels of the antigen coming to the body. But ingestion or injection are kind of the worst two because the antigen is still in the body and it's still allowing that antigen to release, and then the body releases histamine to remove it, but the allergen's still in there. With a sting and everything, you kind of have a finite amount of allergen, and the body can handle that with the histamine. But with a significant ingestion, the body couldn't. And I think that's why this person was so refractory. Like, I think that and him being 110 kilograms estimated really made it so he was so refractory to all the treatments until we got there. I'll say this, like, I got a good job, but you should IO'd him and give him the correct medication. If you have to keep giving IM doses of epinephrine as a bridge to an IO and an infusion, do so. But if you give 3 doses of epinephrine and they still need it, you need to bridge to that infusion. That's the big thing. I had to talk to the medical director about it. Somehow I didn't lose my license because I kind of was honest about it. But the one thing I learned from this is like, hey, mix up your sites if you're going to do multiple IM injections. Hey, be aggressive with it, but then switch to the allergen. Can I have, you guys don't have to say anything. Can I have Eastman and Rachel? Do you guys have anything to add or anything like what you see and whatnot? Because you guys have a much different perspective as me, and I appreciate it. If I did a good job. If I didn't do a good job, just yell at me and we'll go from there. Either of you? Great work. Thanks, Rachel. Does anyone have any questions about this? I did a lot of research after this call because one, I kind of just was awestruck about like how refractory and like how you can take this person from like near death to his prognosis. His prognosis is he was discharged by a doctor I will not name 4 hours later, and then he had an appointment the next day at Dartmouth Allergen Clinic where he got an EpiPen and they told him not to eat Domino's pizza anymore. So this call's in Berlin if you ever have to go to him. If he had Domino's again, call him an idiot and then be aggressive with epinephrine. You'll be fine. Cool.
I have a few things, Scott, than anybody else can follow up or ask any questions or give any final words. Did you guys how hard was it to move this guy? Because I would be pretty nervous personally. I mean, 220 pounds, it's not like big, but it seems like this probably would have been he would have been all there and maybe relatively limp and not able to help you guys. So depending on
that was a big problem. His entire extended family was there for a funeral. And his wife was like, there was nowhere for the people to go for us to IO him and him to scream and not that. And like, I know that shouldn't play a role in it. It really did. We tried getting him to his feet, and as soon as we got him like 20 degrees off the deck, like his feet at 20 degrees, he just fainted, and we had to lay him flat again because he was so positionally orthostatic. We called for Berlin fire department, but they didn't respond for whatever reason. They responded enough, so we called another crew, and Spike Hendrickson and Chase Eastman arrived. Chase got to give epinephrine number 9, so congratulations, Chase. And I think it was one of those ones where like if we had more people that were trained that were willing to help, we could have just like thrown him in the stretcher, got him to the ambulance, and IO'd him there. But I was kind of being too nice, um, which sometimes is a problem. But yeah, he was very limp and he was very like sweaty and just like that like peri-arrest pale is a good way of saying it. He wasn't as red as I would think he was, but he did have like noticeable urticaria on his body, which we didn't give him any Benadryl because he already took some.
Sweet. I would be suspicious that anything in his digestive tract is probably not digesting well, given that the entire thing's inflamed from an oral allergen. But and then I might have missed this, Scott. Did you
Oh,
give
so
him any
what Rachel
albuterol?
says, he would improve, decline. So pretty much we would
Oh
like
yeah.
he would be getting better, he'd be talking to us more, um, and he'd be more that verbal responsive, and then we would move him, and as soon as we moved him, he would be positionally orthostatic and he would decline. So that's why we literally just waited till the other crew got there, put him on a mega mover, threw him in, and started driving as fast as we could to the hospital.
Yep. Um, did you guys give him, did he get any albuterol or was he like just hypotensive or did he have airway problems too?
He
I might
didn't.
have
He
missed
just
that.
had a noticeable facial edema. He didn't have any audible wheezing that I heard.
Hmm.
Um, I think it was because it was a ingestion route rather than. I don't think it was as systematic. Well, it was systematic, 100%. I don't think it was having a as much of a lung issue as that. Like as soon as we put him on the 15 liters, his oxygen went up to 100%, oh, like 96%. Um, so like I didn't see the need for a albuterol because
Mhm.
I wasn't getting those um, increased pips and those bronchoconstriction that I saw. He probably would have benefited from it, to be totally honest with you. I was just like giving a neb to someone that's flat on the ground is always difficult. And I was kind
No,
of
I
busy
agree
just
with you.
drawing
I
up
just
every 2 minutes.
my
Something
thought
I
behind
do,
this
and
one.
if you ever see me do epi, anytime I give one shot, I've never just given one shot because I'm a baller. Um, I draw up another one immediately, every time without fail. The only thing that I wish I did is that I realized after that third or fourth, because I don't mind how many I gave, I just mind that I chickened out of IO access for this person. And that's what it was. I didn't want to IO him in front of his entire family. I should have. He probably would have improved better, and I would have definitely had more of a hemodynamic control rather than me giving him IM epi so he doesn't decline again. Um, I think when you have that epinephrine infusion, you have the ability to control his hemodynamic stability rather than uh, doing witchcraft with IM epi. So that's my big takeaway from it.
Sweet. Yeah, IV in the
Um,
hospital.
so he got an IV in the hospital, Eden, but because he went from, um, it's kind of that case where you fix the problem and you bring him to the hospital. The hospital didn't believe he had a significant enough um, exposure. They thought we were just too aggressive with epinephrine. I think when he vomited out a majority of that antigen. And as Mickey said, he was since he was in shock, his gastrointestinal tract wasn't absorbing as much. So he did get an IV in the hospital. He got monitored for 4 hours, and then they sent him home with an EpiPen. And then he went to Dartmouth Allergy Clinic the next day and got a allergen test, which I think is kind of a bold move, but they know more than me. So it was definitely a weird one. Like Eden, I'm telling you, he went from like unresponsive at the staircase to alert and oriented, thanking us for being there. 100% night and day.
Sounds refractory, which is kind of the whole point.
Yeah.
That's one of the more significant, short of criking somebody, that's probably one of the most significant anaphylactic type cases that I've heard about, Scott. I do want to add or touch on one thing. You are correct, Scott, that Dex for anaphylaxis is in the extended care protocol. So it'd be like they would administer at the hospital once or twice over a day or two. However, with persistent broncho constriction or airway, like if the patient requires NEBS, I would argue that you can make a protocol pathway argument towards reactive airway disease because the airway is reacting to the allergen. So you're definitely following the anaphylaxis protocol, but you could use probably dexamethasone as a standing order for reactive airway disease. That being said, like we previously mentioned, I think there would be a little bit more thought consideration into treating an anaphylactic patient with BiPAP than there would be a COPD emphysema patient. So I think you certainly could make the argument and follow protocol with Dex if there is the need for continuous airway treatments like albuterol, oxygen, or the patient has wheezing or stridor or anything like that. And then the last thing, there is, in the QA, QI side of things, there is a noticeable discrepancy with airway patients in general not getting 12 lead EKGs. So this is the last kind of part of this. I think that, there's certainly the likelihood that a patient could have a breathing problem due to ventricular MI that's causing pulmonary edema from a heart failure induced by an MI. So I think in that sort of setting, like vague, then I think you should do a 12 lead. I certainly would not prioritize a 12 lead in an anaphylactic patient, especially if you can say for sure this is anaphylaxis. I'm giving epi and the patient's responding to it, and they have a known allergen which they were exposed to, and they have like urticaria and things like that. So I think there's not really an argument to do a 12 lead in the same sort of logical way. However, I will say in an older patient with pre-existing cardiac disease or previous MI or coronary artery disease, anything like that, it might be worth doing a 12 lead at some point if you're with the patient for an extended period, just because epinephrine could obviously induce some degree of cardiac strain. So it might not be a bad check the box. So I wanted to highlight that in general, I think we need to do more 12 leads with respiratory patients. There's probably likely to be a lot of artifact if the patient's breathing really fast. But the caveat to this is that the anaphylaxis specific patient probably doesn't need a 12 lead as a requirement, but understanding that patients with pre-existing cardiac conditions can have unanticipated complications from high dose epi stressing the heart, especially if they're older with heart comorbidities. So that's kind of my little 2 cents about that. So does anybody have anything they want to add or any questions? This was about an hour. So Keith, I see you. Anybody with somebody that didn't say who they were with? Yeah, everybody else works for Berrytown. Going once. Going twice. Scott, by Spike, did you mean Mike Hendrickson or did you mean Mike Bellinger?
Spike as Mike Hendrickson.
Oh, he's with you?
Yeah.
Or he was with you on the call.
Oh, by the way, guys, if I ever do something outside of protocol because I do things with my heart, let me know during the call. So after the call, when I'm doing the run, I can know that I went out of protocol and tell people so I don't look like an ass. He was like, yeah, you're already way past. And I was like, yeah, but you could have told me that, brother. So just heads up. If I do something out, let me know. I may not actually know I did the wrong thing. I'm not perfect. I just try to do the best I can. So I think you've all seen that.
Scott? Okay, I will stop recording this meeting unless anybody raises their hand in the next 5 seconds. Thank you all for attending. I'm going to put out more information in the next week about the itinerary for November's refresher course. So kind of plan on the 14th through 20th, that sort of time frame. We'll get a lot of skills knocked out. So I'll send that out and then I'll put everybody in for credit for this. The next online thing, David is going to be doing a siren documentation training at the end of October. So I'll send a reminder at the end of October for that too. But it is in the calendar. Thanks for tuning in, Ben. Have a good night, everybody.
Thanks, guys. Bye.